Okay, good morning, good afternoon, and good night. Welcome to the webinar, Epilepsy Surgery, Case by Case, Step by Step. This webinar is a part of activities of Epilepsy Surgery Task Force, ILAE, Asia, Oceania. This webinar is organized trying to reduce the treatment gap of epilepsy and epilepsy surgery in Asian Oceanian region. And this is the 7th session of temporal lobe epilepsy series. This is the last webinar of this series. So this time we'll discuss about semiology differences, compare the semiology between pediatric and adult temporal lobe epilepsy. And we'll summarize the temporal lobe epilepsy section. And before the start, let me introduce the co-convener of this very popular webinar, Professor Sarat Chandra of India, and the Professor John Dunn, the president of ILAE Asia Oceania, and Professor Akio Ikeda, the past president of ILAE Asia Oceania. And as usual, we'll start with the Professor Manjari Tripachi's presentation of case. And I'll give the chair to the Professor Sarat Chandra to introduce today's faculties. Please. Oh, you are muted. Okay.
Thank you so much, Professor Kawai. On the behalf of Asiano-Oceanic International League Against Epilepsy, we welcome all the delegates for another exciting and the final session on temporal lobe epilepsies. At the outset, I would like to thank the leadership of AOILE, especially Professor John Dunn and Professor Ikeda, for allowing us to create this webinar series, which we really hope will be useful to all of you. I have the pleasure of introducing the faculty for today. So Professor Joyce Wu, who is a section head of epilepsy program, attending physician neurology at Lorna S. James P. Langdon Chair and Pediatric Neurology from the Northwestern University. Her clinical interests include neurology, epilepsy, epilepsy surgery, tuberous sclerosis complex. She's done her education from New York University School of Medicine in 1995 and did her fellowships in pediatric epilepsy and neurophysiology from UCLA Mattels Children's Hospital from 2000 to 2002. And she did various fellowships in child neurology, Floating Hospital, New England Medical Center, Boston, and also residence in pediatrics from Boston City Hospital. She's a highly acclaimed pediatric neurologist, and my association with her goes back when we were at UCLA, and we were quite impressed with her brilliant discussions on how to take forward patients for epilepsy surgery. I also have the pleasure of introducing another distinguished faculty, Professor John Stern, who is a very well-known figure. He happens to be the director of epilepsy surgery training program at the UCLA, which is a world-renowned center for epilepsy, and is a professor in the Department of Neurology and director of Epilepsy Clinical Program. He is well known for being the co-author for the epilepsy textbook by Professor Pete Engel, which is considered one of the Bible for epilepsy surgery. And he's also authored a very beautiful atlas on EEG, which again happens to be a Bible for everybody who wants to become an expert or learn about EEG. So with this, I will now request Manjari to go ahead with her case presentation. And following this, I will ask our faculty to give the lectures.
Thank you to the panel here, and thanks to Dr. Ikeda, Dr. John Dunn, Dr. Kensuke. And we dive straight into the case, who's a 12-year-old boy. And he's had seizures since the age of 10 months. And obviously, by the time he's come to us, it's been 11 years since he's been seizing. The frequency is ranging from as few as 4, which is quite a lot, to 20 a day. And there's a history of febrile seizures present when he was around 2 years of age. However, there was no interim period of seizure quiescence from 5 years onwards for a few years. He just went on having seizures. These febrile seizures which he had were very typical febrile seizures, and he had received phenobarbital in his childhood for that and was eventually switched to other anti-seizure drugs. There's no history of head injury or viral encephalitis. The semiology as given by the parents, even at the age of 12 years, is sudden stiffening and falling and sustaining injuries. And this would happen around 2 to 3 times in a day. And several episodes, almost, amounting to 20 odd, where his head would just drop down and he would, if he's standing, fall down again. As I told you, there was no significant perinatal history. There's no history of hypoxia. He was born normally and had apparently, developed normal milestones till about 1 year of age when his seizures came in. When he came to us, he was on a good dose of anti-seizure medications and continued to have these episodes. So you see here, it's trying to just. So that's virtually the end of the event, and he had several such events in the monitoring unit. So we'll discuss the semiology here, and from the look of it, it seems that he's just sitting on the bed and his head just drops down with loss of tone, and he has a complete loss of tone, and he kind of falls down onto the bed. So Joyce, I'd like your opinion. At least from what we saw, we couldn't lateralize or even kind of localize where the seizure onset would be, despite this child having many such events in the epilepsy monitoring unit. So I'd like an opinion by Joyce and Dr. Ikeda and Dr. Kensuke and of course John Stern.
Yeah, so good morning or good night, good evening, wherever you are. The video that we just saw, I agree that there's really not a whole lot of lateralizing or localizing signs here. It does, to me on the video, looks like he kind of fell to the side and perhaps fell to the side and back and lay there for quite a while and then just sat up. And so to me, again, I agree with you that there's very little lateralizing or localizing signs. And that is actually something that I'm going to try to discuss in my part of the lecture.
Dr. Ikeda, Dr. John Dunn, Dr.
Yes.
Kensuke.
May I say, initially, could you hear me?
Yeah.
Yeah, initially the patient actually, as you said, that the head nodding, but he actually raised his the bilateral hands in the middle in the air. So that's alternative explanation is some sort of not strong but some the stiffness as you mentioned. So at the time of the beginning of the seizure, stiffening has happened that the patient with temporal lobe epilepsy, if that the seizure activity can spread into that the frontal area, or it can spread down to that brainstem, making that the generalized, the so-called stiffness or generalized tonic seizure-like period. And then the patient actually shows that the quite slow lying down on the bed in the cubitus position. And then he starts showing some sort of presumably hypersalivation, because that they actually the swab that the mouse, and then his right hand is now showing that automatisms. So sometimes we encounter the patient with temporal lobe epilepsy showing that some the stiffness are presumably responsible by that the brainstem involvement of frontal lobe, but at the same time, temporal semiology can happen together. So the once we take that the some automatism of the right hand, it can be weak the lateralizing sign of the ipsilateral side of the seizure. So although it is the weak, but we could mention that the patient's seizure focus may be on that the right temporal. I understand this is a case of temporal lobe epilepsies. That is my discussions. Thank you very much.
Yeah. Any other viewpoints? We
Yeah.
were not very convinced about the right-sided automatism, so he moved his hands and he moved both of them. The right came in a little earlier. So, yeah.
Yes, as we all know, this is kind of tricky because just looking at the semiology with his head dropping and then the bilateral and fairly prolonged tonic posturing, we can't be sure whether this is a generalized onset or focal onset seizure spreading to become bilaterally tonic. And we know that at any age, quite commonly, as Kyo mentioned, in frontal lobe epilepsy and the posterior extratemporal epilepsies, that, if you like, bilateral tonic seizures are not uncommon and can sometimes lead us astray as to thinking that we're dealing with a generalized rather than focal process. And as Joyce no doubt will cover, in children, particularly infants and preschool children, this is very, very a scary possibility. Even temporal lobe epilepsy can present with marked tonic and myoclonic, even epileptic spasms, and then they have a clearly focal lesion. But looking at this young man, I think none of us could be confident about whether we were dealing with a focal or generalized onset seizure disorder, and if it was focal, whereabouts it's going to be, because there are a number of possibilities.
So any other view, or shall I proceed? Yes.
I quite agree with Dr. Jordan. This time, only from this video, we cannot be sure about whether this is generalized or focal, and so yeah, I want to see EEG.
So basically, the reason I put this video out is that many of these children will get bundled as generalized seizures and probably not even undergo an evaluation for a possible focal etiology or a surgical substrate for epilepsy. And this is what happened in him. Really, his seizures started way down at 10 months of age, and he came to us at 12, lost out on everything. So the ictal onsets, as you can see here, pretty much started with this generalized sharp and spike and slow, or sharp and slow, whatever you call it, with slightly higher amplitudes on the left anterior regions, especially around the temporal, but also spilling over anteriorly. And they're seen, the same is seen on the right, but it's slightly lower in amplitude. So the onset is followed by this attenuation, which is again looking seemingly bilateral. And this is followed by some kind of a fast activity, which isn't so well seen on the right side, but seems to be a little better delineated on the left anterior region. And then there's a kind of a slow sharp, which comes in later on towards the last part of the epoch. And then it goes on like that with appearance of spikes and slow waves, and then he continues to be in the event. So pretty much this is his event. And this is just to show you in the bipolar circumferential, showing the same, slow and sharp, followed by an attenuation for a few seconds, followed by the fast, which comes in. And really nothing much is lateralizing on the ictal onsets here, unless we want to put weightage to the higher amplitude on the left side with a little bit more fast activity on the left side. Joyce, would you want to opine on these ictal onsets? Joyce? She with us?
Sorry, here. I'm trying to squint on the screen. It looks very generalized to me, perhaps, like you said, with somewhat of a lead-in. It's hard to tell, at least on my screen. Even the fast activity that follows. Sorry, let me just see. This is average referential right now. Okay. I mean, if we're thinking of some kind of surgical intervention, I don't think I can really rely on this particular EEG to decide surgical intervention or not, meaning it's still not very lateralizing to me.
Okay.
Or look like.
Any other opinions on the ictal onsets? Whether we could kind of have some kind of suspicion onto the lateralization, or we put it as a generalized onset?
Manjari, what does it look like on other montages? Because the average has its limitations.
I just have, the second choice I have here is the circumferential bipolar, which goes around the head, so, and then transversely. So this is the onset. John?
Yeah, I think you bring up a very interesting point here about this dichotomy that we're touching upon between focal and generalized, and each of the other comments were quite apt. I think ultimately it's a matter of consistency. And so, yes, there's asymmetry to the EEG, and yes, there's asymmetry to the manifestation of seizure behaviorally. Both of these tests, behavior and EEG, are somewhat informative, but not nearly as informative about focal pathology as imaging, of course. But these technologies, including behavior as a technology in terms of our interpretation of it, are best judged in consistency in the features over time, among seizures. So maybe one question would be, how reliable are each of the EEGs with each occurrence of the seizure, numerous seizures?
Okay, so I just wanted to know, if you look at the literature and you look at Doug Nordley's series and Dr. Kotegel's, what's mentioned is that up to the age of 6 years, they can have these generalized semiologies. And really the focal patterns don't set in semiology-wise or ictal onset-wise. But this kid is 12 years old. How commonly would one, even rush in to investigate for a focal etiology or a surgical substrate if at 12 years of age we were finding the semiology and this ictal onsets? It would be misleading for us, and we would probably, many physicians or many pediatricians or epileptologists would, of course, the epileptologist would kind of still want to rule out something which could be a surgical control for his seizures, but this could be really misleading for many clinicians to not fast track these kids, as in this kid, for a surgical control.
Certainly, I agree, Manjari, but one of the things that, and John touched on this a moment ago, that obviously it's the clinical context, and even it doesn't matter whether this is a 12-year-old or a 34-year-old. And for example, I can remember a number of my patients with parietal lobe epilepsy, some who'd had perinatal stroke, where they have absolutely typical generalized tonic seizures, brief, and you'd say, oh, well, this is absolutely typically generalized, and the structural imaging shows that they've got a clear-cut perinatal stroke or other lesion, and we know the limitation of tonic seizures as being more widespread than the actual onset is because of the rapid neocortical spread. So it's a whole picture thing, and so whether it's a 12-year-old or a 42-year-old or a 34-year-old, I think we need to keep in mind that such tonic seizures can be of focal onset at any age.
Okay. Any other comments?
May I ask one question?
Yes.
You show that the nice video of this patient. The clinical semiology, as you mentioned, that the patient initially have stiffening and the falling rate, and then the speaking of some sort, presumably the hand automatism. It seems to be happening on the right side. It's always happen after the so-called presumably a tonic seizure, or it is just a matter of by chance of these videos?
No, this wasn't a consistent finding across all the events which he had. So that's why I did not mention it separately. So it was seen in this one, but it's not seen consistently occurring in others.
Okay, so the mostly that the common semiology is that the stiffening and then the falling, that's all.
Yeah.
Am I correct? Okay. Thank you.
So again, there was a very important point raised here that in the parietal lobe, you can have this, bilateral tonic and sometimes a symmetric tonic. So this mismatch between the location and the semiology is more in parietal and posterior and maybe even frontal sometimes. But with temporal, it generally is that it's easier to kind of find a concordance between the semiology and the ictal onsets, though it may be different. So we now go on to his interictal EEG, and this is again a bipolar double banana montage. And we can see in the interictal, there are these sharps which are seen around T1, which is pretty consistent with some almost like temporal rhythmic delta seen after the sharps. So this was something which was found in his interictal record. Any comments on this interictal epoch? So this, and then you have this, and then you have these slowing with sharps coming in after this around T1. Anterior temporal on the left. So this was kind of a clue for some kind of lateralization. And yeah.
So again, as John has mentioned, the inherent consistency is the issue here. And like, for example, on the first second, there's what appears to be a sharp wave maximal frontally at F3 rather than temporal. But certainly that train of sharpened semi-rhythmic theta and delta is notable. And if it's consistent over the monitoring, is certainly of concern.
So, of course, this was something which was, again, flagged by us, and then he had no visual field defects or motor sensory defects, but all his 11 years of seizures had left him with low social quotient and mental age of 2 years only. So he was profoundly retarded, and probably this could have been cut short if he had been detected to have a surgical substrate earlier on in life. And this is what his MRI showed us. Of course, you can see this transmantle sign here. I don't know if this is very clear in the next pictures, which appear dark. I do have the videos, but because I don't want to impinge on the time, I'm not showing the flow of the videos on the MRI. So clearly, the ictal SPECT with CISCOM, and this is the PET MRI fusion, as well as the MRI. Of course, the MRI was very, very clearly showing a type 2 transmantle sign. So any differences of opinion on this? And this was the left temporal. Yep. And the MEG was also consistent with the mid-temporal dipole. Also, a dipole was seen in the insula. Of course, he underwent ECOG-guided surgical resection, and he's been seizure-free. Though intellectually he hasn't improved much, but his behavior has shown some improvement, and he has been going to special school. So this is another similar kid with a different EEG pattern. I just show the video quickly. We didn't discuss it so much. So much similar with uprolling of eyes and hand. And here you can see the interictal EEG showing frequent sharps and spikes around T5 and maybe anteriorly also, again on the left. And the ictal onsets are characterized by this fast activity, which comes in around T3 and T5, as can be seen here, which evolves in amplitude. So unlike the first patient here, there was a clue on the ictal onset of a kind of focal paroxysmal fast, which is seen around T3 and T5. And of course, this patient was very similar in that there was a type 1 dysplasia, which was removed surgically. So this is in contrast to the topic we discussed today of an adult with temporal, where there's an epigastrium. Of course, there is a lack of awareness and repetitive automatisms of the right upper limb, as can be seen here with these. And he has a prolonged episode, which is followed with oral automatism. Not responding, there's no forced function. These kind of automatisms go on. So this is in contrast to the first two kids which you've seen. And with this, this video is already on the ILE website. This was discussed in the first case. I'll stop sharing my slides and we will go on to the discussion.
Manjari, can I make a question about the first case? From a surgeon's point of view, so you did the kind of extended temporal lobectomy, but as EEG showed, the epileptic discharge was found not only in temporal lobe epilepsy but frontal lobe epilepsy, and his IQ is impaired, so that suggests very the widespread impairment. So usually we don't expect the seizure termination only by the temporal lobectomy, but in this case, you could achieve the seizure freedom.
Yeah. Structurally, it was only the temporal lobe which showed the dysplasia with the transmantle sign. There was no lesion in the frontal lobe at all, and there were no neurocutaneous markers to suggest that he could have multiple lesions in the brain, either of TS or TS associated with dysplasia.
Mm-hmm. You see, there is, there's a paper by the Professor Wiley. Even if the EEG change is generalized, but if the patient has the image, the unilateral image, the MRI lesion, then you can expect the seizure freedom by not very focal, but for example, the hemispherectomy. So how you decided the extension of the resection?
So of course we had a type 2 dysplasia, which is relatively better to figure out in terms of its margins. And of course we had the ictal SPECT with the syscom and the PET hypometabolism, and we ended up doing a electrocorticographic guided resection. There were very frequent bursts of spikes which were seen, and we used that to guide the resection margins in the OR.
Okay.
Maybe I could answer here.
Mm-hmm.
So we follow the UCLA strategy for all the well-delineated cortical dysplasias, especially for type 2, where we expect the amount of resection to be not so diffuse and kind of limited. But despite that, we almost end up excising 30 to 40% more than what is there seen on the MRI imaging. We do heavily rely on electrocorticography, and we follow this grading system, which has been very widely used by Dr. Gary Mathern. And we do a pre-op and post-op, and often we may end up doing resection at least 2 or 3 times, tailoring the resections at least 2 or 3 times. So this has been our strategy for type 2 dysplasias. Now type 1, we again go in for an extensive resection provided it's in the temporal lobe. But if you find a type 1 in the frontal or any other portion, so obviously we need a little bit more evidence than that. So that is where we think of doing an SCG to look for the extent of the resection. But a type 1 dysplasia, especially limited to the tip of the temporal lobe and kind of extending, and when we have confirmed that the memory is not going to be impaired, so we do a radical temporal lobectomy, and with this we've had good results.
Okay. And so you mean by the intraoperative ECOG, so you use the kind of intraoperative spike? Well, recently, many groups use for example, high frequency oscillation, the online analysis.
Yeah. No, we haven't done this for this patient. We do have high bandpass EEG systems which could help us with that, and we haven't done that for this particular kid. Yes, of course, it could be done. So this is just to show you the articles you were referring to, Dr. Kensuke, is by the Cleveland Clinic Group, of course, first reported by Dr. Ajay Gupta and his team, and then by Elaine Wiley. So basically, they were focal lesions with generalized EEG findings, and the methods of lateral, and some of them were even hemispheric. So we can see here there was cystic encephalomalacia, malformations of cortical development, etc., which were responsible for generalized abnormalities, even in focal lesions.
So may I ask 2 questions? So first is, before I ask my question, after asking the question, I would like the opinion of both John and Joyce of what would be their strategy for such lesions. And my comment is that you showed a patient who has a generalized discharge, especially in a kid. Now in resource limited settings, when you get a drug resistant epilepsy in a child, what are the red flags which you would advise? And this again is a question to everybody in the panel, which will kind of make you suspicious to investigate the patient further. Because any kind of investigation, including an epilepsy protocol MRI, so obviously we need to do that. Many times these type 2 lesions are missed out on a regular MRI film. And plus they have to be seen by an epilepsy sensitive radiologist. And most of the general radiologists don't pick up these lesions. So what are the red flags? And this is an advice to all the people who are watching, especially from the resource limited settings, where you advise to go in for more investigations.
Joyce, do you want to go first?
Sure. Let me the red flags, in resource limited settings, to me, if it's bilateral, symmetric, like in the first case, the 12-year-old, where there's not a whole lot of lateralizing signs, potentially one red flag is there something that is always starting or sometimes starting on the opposite side of the body, right? Meaning it is suggesting that seizures could be coming from the other side or the other hemisphere. That certainly could be a red flag. Bilateral independent spike discharges. Again, just referring back to the first child, if it were just left temporal, if I'm remembering right, that certainly would be more convincing. But if it's left and right independent, that might make me a little bit more worried. And certainly, some of the imaging tests that Manjari just showed, if MEG were also scattered, or if the PET scan was showing something else on the other side, right? Those all could be potential red flags to me. And let me stop there and give John the space.
Joyce, at Northwestern, would you manage the patient exactly the same way, or would you differ?
Would I defer or refer?
Differ. Would your management be a bit different?
Oh, be different. Sorry. No, I think, just again, thinking of the first case, which was the most sort of confusing or the least lateralizing, we probably would have done the same, meaning, okay, we get the video EEG, we don't see a whole lot of laterality or localizing findings on the EEG. We would definitely do, the highest resolution MRI, followed by interictal FDG PET. If we need to further tease it out more, Meg and SPECT definitely would be things that we would go to also. Neuropsych might be helpful here, but I don't think there's a whole lot we would add to what you've already done. We probably would also do ECOG guided resection, both pre and post, just to make sure. Yeah, let me stop there.
John, your comments on this?
Yeah, I think the cases are fascinating, and I think they touch upon not just the division between pediatric and adult, but the division between focal and generalized for reasons that the others have already commented. And my interpretation of epilepsy is that there is a continuum, and that there are going to be patients who have an epilepsy that is not classically focal or generalized. And these patients may be treatable with surgery, even if the features do show generalized features, as Manjari showed. And so ultimately it comes down to consistency of seizures and EEG based upon a lesion. And so this patient who became seizure-free proved this was focal because of surgical success. But Sarah, your question really is, how do we find these patients efficiently and bring them to surgery? Because it's the other way around. It's having a large patient population and not moving back from a patient who was successfully treated. And so when I think about resources and utilization, maybe there are different tiers. And so the first question is maybe a large population where there is an epilepsy surgery center, but the question is which patients in that population of whom screening is difficult can come forward. And I would go back to the history and really the seizure manifestation as being the first marker of when to be suspicious for potential surgery. Ironically, in our current era, even in resource poor situations, videos are possible because how ubiquitous smartphones are. And so I think, in fact, your group has discussed this, has published on this, if I remember correctly, because if there's a collection of videos that suggest a behavioral focality, some type of feature that speaks against the generalized nature based upon history of age of onset and intellectual deterioration, or maybe even a scalp EEG that was generalized, I think that consistency in the video from home videos with phones would be the first point of escalation, even in a resource limited situation. I think the second tier in terms of resource limitation would be whether intracranial monitoring is possible, because there'll be situations where the resources are present for scalp monitoring and for MRI. And so maybe the point is to get the imaging if the seizures on the videos show some type of focal feature. And if the MRI shows something that's focal and compatible, I think that would push it forward towards surgery, which is, of course, the situation here. And then the question is, how often do you have to do intracranial monitoring? But that's, of course, a much greater resource to use. I was pleased to see the SPECT in this case, because that may have provided a sidestep of identifying functionally some type of focal abnormality beyond the scalp EEG. And so, you know, that question of when to go to intracranial maybe is a question that goes beyond resource-limited environments to the entire world, because we're still trying to figure that out. Is how often is it absolutely necessary, and how often can we dispense with it for reasons of safety and cost?
So one thing which helps us in a resource-limited setting is that if you have a good video EEG, like in the second case, and then you have an MRI, just an MRI, and the image I show up here is from the MRI, it's the arterial spin labeling, which we in India call the poor man's PET. So we can see a huge fusion defect in the left temporal. So the arterial spin labeling takes just another 3 to 5 minutes to do in the acquisition of the MRI, and really doesn't add on to the costs. And this is one thing which could be useful in resource-limited settings when we don't have advanced investigations like ictal SPECT or PET or MEG or even stereo EEG, which is very costly in the developing world.
Any other comments, Professor Dunn?
Just highlighting what John already mentioned. Obviously, in many parts of our region, simply getting an MRI scan of any kind, let alone one which is well sequenced and interpreted, is very difficult. And one of the things about patients with focal epilepsy that then secondarily engage a generalized network and produce these tonic seizures is that commonly they will have more minor, less intense events that can show very striking and characteristically stereotyped focal features. And a smartphone, like John said, is really helpful in that regard, rather than going for the big ones. And we've all seen this in video monitoring too, where we can pick somebody who's had a dozen what appear to be generalized tonic seizures, but tiny little events have much more characteristic focal features that lead us to a focal diagnosis.
Any other comments before I can ask maybe the last question? So my last question is a bit more controversial. And this again is a question open to all the panel. What are the investigations you feel do not require to be done in order to go in for surgery? So fortunately in our center, we have every kind of investigation. We also have a very strong research arm, but in 90-95% of the cases, this is not so. So what are the investigations which you think is not required in these cases? So I'd like to have opinion of each and every person here.
Well, I think your question is provocative, because it's asking, what do we do that we don't need to do? And, you know, a way to sidestep the question is to say, well, of course, there are patients where it's necessary, and so there'll be the exceptions. But if I can interpret the question as, what do we do that might have the lowest benefit overall, not for particular patients, but in the population? I think, and maybe it's biased, that the source analysis EEG or other quantitative EEG approaches don't often, in my opinion, change the manual read or the analog read or the human read, in other words, although those analyses are not very expensive. And so it doesn't save much in terms of resources, but very often I think we end up seeing what we're going to see quantitatively already with our eye. That was the low-hanging fruit.
Okay. Anybody else? Anybody else would like to?
Maybe I could jump in. Just gosh, we already, as a general rule, right, start with the non-invasives, and if the first round of testing already tells us the answer, then we don't go forward with further testing. So in essence, we are already sort of maximizing the yield, if you will, meaning we don't do all tests on all patients. We do select ones that are, going to give us the biggest bang for our buck at the beginning, and then add on more in order to further help us either lateralize or localize. So I guess what I'm trying to say is, every test has its own value. We don't use all of them at the same time. So in essence, we're already paring back, or again, maximize the use of each test. Doesn't quite answer your question, I know, but I feel like a lot of these tests are useful in their own rights when they are needed.
Yeah, and maybe I'll add something, from what Joyce just said, and that is, at least in the United States, there's been a tremendous surge in intracranial EEG or stereo EEG, but my knowledge is that it hasn't led to an increased number of resections or better outcomes. And so the question is this technique being used too liberally and unnecessarily for many patients, which isn't to say it shouldn't be used. But do we have a pendulum swing here that needs to be corrected toward more judicious use of that test, selectively?
Hey, well, I totally agree with Joyce and John. How couldn't I? But the thing is, it's a stepwise process. Let's say that first young boy, let's say he had that lesion and his EEG was concordant. End of story. Do we need MEG? Do we need PET? Do we even need ictal SPECT? No, because we have two independent functional and structural concordant pieces of information. End of story. Now, he wasn't like that. Now, having said that, with an EEG being non-localizing and an MR being apparently localizing in somebody with major intellectual handicap, maybe the MR is showing one element of what might be far more widespread disturbance of brain structure and function. And as we all know, particularly with dysplasia, you can have bilateral, and so then you start to think, look, I need to have ictal SPECT. The PET, for example, might tend to show widespread hypometabolism of the perisylvian regions and everywhere else. So if I was limiting my investigations, I'd be in that young boy going the MR, EEG, and then ictal SPECT, hoping to get concordant again. And then if that wasn't the answer, you amp up the tests. And so it's an incremental process.
May I say? Could you hear me?
Professor.
Yeah, I totally agree that in case of this kind of the patient as a candidate, as Joyce mentioned, EEG is very important. If the patient shows that the generalized and multifocal independent right and left, which suggested that the symptomatic generalized epilepsy, it could be the outside, but once the patient have that the generalized the discharge and also focal spike, that would be one of the important finding. And also the John mentioned that the semiology is also very important. From the experience as an adult, the tonic seizure symptom is also accompanied by some sort of lateralized sign arising from the tempora during the clinical period. So the seizure, which can be recorded whichever by the home video and so on, that's very important. But for children, I just wondering that the ictal SPECT may be one concern, because that is actually the final, not really the snapshot, but it's some sort of a whole shot which can tell us that the degree of involvement, the whole brain activity. So ICTA spec may be one concern to hold from my point of view. That is my comments. Thank you.
Thank you, Professor.
Sarat, there was a question in the chat.
So the question is, this is from Dr. Shah from Kochi. So will you recommend going ahead with pre-surgical evaluation, which includes PET, MRI, MEG, and SPECT, in a teenager with absences in presence of a type 2B FCD on MRI with generalized 3 Hertz spike and wave disturbances, specifically in a resource-limited setting?
May I take that question?
Yes, John.
My consideration of whether to go ahead would depend upon the location of the FCD. And as a point of reference, there was a paper years ago from, I think Carter Sneed was one of the authors, looking at what was then called benign Orlandic epilepsy, and patients who had been successfully surgery treated for it, which raised the question of why they needed surgery, because they had medication-resistant epilepsy, but it was diagnosed as benign Orlandic epilepsy. And what they found is those patients who were successfully treated on histopathology post-operatively was found to have FCDs. And so I'm using that case series as a point of reference because, I wonder if a focal lesion in the right location can mimic a generalized epilepsy because it's affecting the network, pardon the expression network, because we use it so generously these days in a way that allows for mimicking. And so if that FCD is in paramedian regions, which are thought to be electrophysiologically abnormal in absence epilepsy, I would think that maybe it could mimic an absence. And maybe the diagnosis is not absence, even if the EEG and seizure manifestation are typical absence. If the FCD is in occipital pole, maybe not.
So Dr. Ikeda has written, they have reported a similar case in epileptic disorders, 1999. So basically a focal lesion rapidly engaging bilateral cortical networks, mimicking absence, should not be a contraindication for just dumping the patient as having absence seizures and trying all kinds of medicines and patient not responding. So I think with this case and John's comments, I would also want to, give the benefit of a surgical investigation for pre-surgical evaluation in this case.
So thank you very much. So that brings us to the conclusion of the case discussion. So now I will request Dr. Joyce Wu to please present a lecture on semiology of pediatric temporal lobe epilepsies. And then we will have Dr. Johnston presenting on the comparison between pediatric and adult temporal lobe epilepsies.
Sorry about that. Can you all see the screen?
No, it says you're sharing screen, but we saw the PPT. Yeah, now we can see.
Ah, perfect. Okay, great. Let me get started. Thank you for the great cases just now. That is a great setup for the rest of my talk, really, on the semiology of temporal lobe epilepsy in children. And so I'm going to take a little bit of a different approach and show you actually 4 different videos to start. So the first one, hopefully the video works. Hopefully you can all see that. bilateral arm extension, elevation. That looks to be symmetric in a cluster. Let me stop the video here. Oops. The next video is asymmetric jerks, more involving the left side of the body, also in a cluster. So I should say that the first child was about 6 months or so. This second child is about 9 months or so. Oops. This next video, he is about 2 years of age. Right arm fisting, right hand fisting, right arm tonic posturing here. Hopefully you were able to see that. And oops. Fourth video, this is a teen who, play it here. I apologize for the audio here. Who's just sitting around with his family doing jigsaw puzzles. And pretty soon he'll look over to his right. I know it may be hard to appreciate his face expression changes. He starts to breathe differently. And pretty soon the fumbling comes in. And certainly the staring and the behavioral rest. And harder to appreciate, but there's some dystonic posturing of that left arm. Let me stop the video here. Oops, I cannot seem to do this right. Okay, so even though I'm supposed to talk about semiology of temporal lobe epilepsy in children, I thought I should start with a little bit of what it looks like in adults. I'm sure Dr. Stern will go into more details. So in adults, about 90% or more of adult patients with temporal lobe epilepsy will have auras. More specifically, any one or a combination of these, epigastric rising, fear, deja vu, jamais vu, olfactory or gustatory hallucinations. They could then go on to have motor and or behavioral arrest with the retraction of palpebral fissures, pupillary dilation, the decreased responsiveness and alteration of consciousness. They could also have automatisms, which could be oral alimentary, such as lip smacking and chewing, or upper limb automatisms such as picking or fumbling, all of which we saw in the teen example. That was the last video. I should also mention that this teen was able to report historically by parents' description epigastric feelings, just something that doesn't feel quite right in his abdomen, as well as some deja vu reports as well. Lastly, in adults, dystonic posturing, a wider range of 15 to 70%. The contralateral upper limb offered lateralizing in 90 to 100% of these patients. So this is what we usually see in adults. And again, Dr. John Stern will go into more details after me. So what happens in kids then in temporal lobe epilepsy? So in general, infants and young children have quite limited ictal manifestations or ictal behavior change. In temporal lobe epilepsy, kids 3 years and younger often will have early and marked motor features, such as tonic, myoclonic, and infantile epileptic spasms, which would actually decrease as they get older with increasing age. So the first 3 videos demonstrate that quite well with clusters of spasms and a tonic seizure, focal tonic seizure in the third example. At least in one study in 29 kids, those kids younger than 6 years of age often had symmetric motor phenomenon of the limbs up to 80%, and then becoming less and less frequent in the older kids, about half of that at 40%. And that was demonstrated in the first video with the bilateral symmetric arm elevation and abduction in the cluster of spasms. Seizure semiology in children older than 6 years of age then become very similar to that in adults that we just saw. Automatisms become increasingly complex with age. So initially, maybe starting in the younger age group with oral alimentary and gestural, perhaps blinking in the preschool kids, and then becoming more complex, such as the fumbling of the hand in that teen example. Furthermore, younger kids, again, referring to 3 years and younger, are more likely to have generalized seizures up to 77%, at least in one series, and less likely to have lateralizing features, which we also saw in the earlier videos from Manjari. Motor manifestations often are symmetrical, non-lateralizing, and younger kids are less likely to have localizing features compared to adults. And younger kids are also less likely to have auras, or perhaps too young to even be able to describe having auras. And hypomotor, or quote unquote subtle seizures, are very common in preschool kids. They are often overlooked as or misdiagnosed as non-epileptic events because they're so subtle. And so that was predominantly sort of seizure description from older literature without the benefit of video EEG. With the advent of video EEG, Ray and Kodegal in 2005 really looked in a lot more details as to the semiology of temporal lobe epilepsy in children. And here is a nice table that they published in this article in terms of both auras, motor phenomena, and automatisms. So in terms of auras, there's definitely an evolution as kids get older. So in the infant and toddler age group, which defined here as 0 to 3 years, were rare and often difficult to recognize. By the time they get to the 3 to 6 years age group, they may be present. And by the time, again, older than 6 years of age, where we already saw from earlier descriptions that they're more likely to mimic the adult temporal lobe epilepsy semiology, auras are now in this age group common, especially the abdominal aura, like the teenager in the fourth video. In terms of motor phenomenon then, again, in the infants and toddler age group, more likely to be prominent, again, tonic, clonic, myoclonic, and as mentioned before, spasms as well, maybe bilateral and symmetric. In the preschool and early school age, less prominent, may show some dystonic posturing by this age group. And again, in the older than 6 years age group, motor phenomenon become less prominent, and contralateral dystonic posturing becomes more common. And in that last line, automatisms in infants and toddlers, again, are common, simple in character, usually lip smacking, chewing, the oral alimentary type. In the middle of that age group, more common, becoming more complex with increasing age, hand automatisms can come in at this age group, along with the oral alimentary automatisms that we saw in the earlier age group. And then in that last group, the older age group, again, common, more complex, more discrete, and certainly, again, more complex in the sense that oral, hand, and verbal automatisms can all be present in this age group. 2 years later, this group also looked at and benefited from looking at video EEG and the semiology of temporal lobe epilepsy in children. Much larger group. They chose to look at adults and kids, so spanning the entire age spectrum, from 10 months to 49 years. And so the first finding I want to share with you here is, again, there is that age group difference. Here they subdivided into younger than 6 to 12, 12 to 18, and then older than 18 years of age. And as you can see here, the secondary generalized tonic-clonic seizure increased with increasing age here on this graph, and so do the automatisms with increasing age. From the same paper, they also looked at what happens to the number of different lateralizing signs in terms of semiology. And with increasing age, there's more and more different lateralizing signs. And the flip side of that is the younger age group has fewer or perhaps not absent lateralizing signs. Again, from the same publication, what about motor seizures? And here is sort of the inverse. They're more likely to have motor components earlier on in the younger age group, and with increasing age, less likely to have that motor component in temporal lobe epilepsy. Lastly, last but not least, there are features of temporal lobe epilepsy that do not seem to evolve with age. So here, what they're trying to depict is the emotional signs, which are the fear or the pain that they're trying to describe here, the vegetative signs, which are staring or the hypomotor, behavioral rest type of semiology, and then the auras. These three do not seem to change over time or change with increasing age groups. And one more study here in 2021, just last year. This study really looked at invasive EEG now, not just the video EEG, specifically in preschool kids. So 23 children less than 6 years of age with invasive recording. And what I found interesting in this publication is that they broke up the semiology types by topology or where in the temporal lobe. So in the mesial temporal lobe, pain and interestingly apnea were described in these preschool kids younger than 6 years of age. Apnea, as far as I'm aware, has not been described in the adult temporal lobe semiology. So I found that very interesting. In the temporal polar group, loss of consciousness and even hyperkinetic semiology were described, which, at least for the hyperkinetic semiology, would think in the adult population more to be frontal in origin. And in the lateral temporal group, loss of consciousness, early clonic or tonic-clonic seizures, epileptic spasms or infantile spasms, and certainly that auditory component were all described, and less surprising here for the lateral temporal group. So a few more slides. Why do pediatric temporal lobe epilepsy present differently from adults? And this also acts as sort of a summary of what I just described. Age-dependent seizure semiology appear to support the concept that brain maturation, significantly influences the evolution of at least some of the aspects of temporal lobe seizure semiology, more specifically what we've seen so far, which are the motor phenomenon and the lateralizing signs. Conversely, other aspects of temporal lobe seizure semiology are independent of brain maturation, which we saw from quite a few of these studies, and specifically the aura and the emotional and autonomic signs are prevalent and common across the different age groups. And what's not clear so far, at least not in my mind, is pediatric temporal lobe epilepsy often are not due to mesial temporal sclerosis as we see in adults, but instead they are frequently due to low-grade tumors and malformations of cortical development, and whether these two large groups of etiology can potentially explain why, at least in early pediatric age groups, these children have different semiology. It's harder to explain, and certainly I would love to find more answers with more studies. And lastly, I just want to conclude with what happened to those 4 kids that I showed you at the beginning of the talk. So video 1, that child that was about 6 months of age at that time with bilateral symmetric epileptic spasms, he was found to have tuberous sclerosis complex. On video EEG, certainly ictal onset from the right temporal area. On MRI, there was a prominent right temporal parietal tuber. And so he underwent right temporal parietal lobectomy / tuberectomy. He's been seizure-free and is currently doing well in high school. The second child in video number 2 with the asymmetric epileptic spasms, also on video EEG, had right central temporal ictal onset. What was found in him was a large hemispheric heterotopia. He underwent a right hemispherectomy, and he's been seizure-free for at least 2 years before he became lost to follow-up. Hopefully still seizure-free. The third video showing that child about 2 years of age with right hand fisting and tonic seizure with the right arm also showed right central temporal ictal onset on video EEG. And here you might wonder, right central temporal with right hand fisting? That seems to be ipsilateral. He was also found to have tuberous sclerosis complex. On MRI, actually no tuber found on the right side, but a prominent tuber on the left central temporal. So we thought that could this perhaps be falsely lateralizing on the video EEG because it's relatively parasagittal. And so he underwent a left central temporal tuber resection and has been seizure-free for 2 years. The last video with the teen showing staring and right hand automatism, left arm extension and dystonic posturing. He also had ictal onset in the right temporal. On video EEG, he underwent a resection of a what looks like to be a tumor on MRI. On path, it was found to be ganglioglioma along with focal cortical dysplasia. And so he's been seizure-free for 6 months. So thank you so much. I'll end here and turn it over to Dr. Stern.
Thank you very much, Joyce. That was a very nicely elucidated lecture. And so Dr. Johnston, you're on now.
Thank you. That was a great lecture. And delegates, you may find that there's going to be some endorsement of Dr. Wu's comments. We did not synchronize our points, so you can take it as independent but cohesive perspectives. I'll be talking about temporal lobe epilepsy in adults. And I'm going to start with just some backdrop to give some perspective and then use some illustrative cases before coming to a conclusion. And so I imagine everyone here is familiar with this diagnostic scheme or this classification scheme from the ILE, which points to seizure types, of course, focal, generalized, or unknown, going into epilepsy types, focal, generalized, combined, or unknown, and then epilepsy syndromes. And I'd like to point out that the arrow from epilepsy types to epilepsy syndromes maybe is a little bit of an overstatement, because not everyone with a generalized epilepsy fits into an epilepsy syndrome. You know, we have classic syndromes that are well characterized, but sometimes a syndromic diagnosis is not possible. But moreover, I would say that most people, the vast majority of those with a focal epilepsy, do not have a syndrome. There are rare exceptions of some focal syndromes. But the idea of syndrome, that is a collection of entities that come together which end up informing treatment and prognosis, are not really available for focal. And ultimately, it comes down to features of the seizure. And so for focal epilepsies, we think about auras as being particularly important, and Dr. Wu covered this already. I mean, I ended up dividing the auras into two types. Those are referable to the limbic system, which are all classic for mesial temporal lobe epilepsy, of gustatory, olfactory, or autonomic changes, including the epigastric rising sensation that's classic, or paramnestic phenomena, or emotional features, is all being highly indicative of the limbic system being involved. And this classically is mesial temporal lobe epilepsy, and then differentiated from the auras that are more neocortical. And auras here I'm using as subjective experiences. Not all focal seizures are auras. I wouldn't consider focal motor seizures to be auras, but one can have subjective or sensory phenomena as the seizure. It's the first manifestation of the seizure. And the neocortical ones would be somatosensory, visual, auditory, vestibular. And so really referring back to primary sensory cortices, which are neocortical, not limbic. And so this is a way of trying to parse out the focal epilepsies and thinking about mesial temporal lobe epilepsy in particular. And so if I had to summarize mesial temporal lobe epilepsy, which is what most people think of when they think of temporal lobe epilepsy, you know, I would say it's typically mid to late childhood onset. And so our question before about whether epilepsy or TLE is pediatric and adult separate, even the adult version typically has onset during the pediatric years, not always. And so that's why I call the talk temporal lobe epilepsy of adults, not adult temporal lobe epilepsy, because these are the patients who had maybe an onset in childhood, but who became adults when they present or close to that. The seizures typically have limbic features, going back to the auras I just described, and maybe cause impairment awareness, and then infrequently bilateral tonic-clonic. Then we end up seeing focal features both on the EEG and MRI pointing to the anterior mesial temporal lobe, along with often deficits in the limbic system, manifested most commonly as memory or mood changes. And then prognosis is variable, and surgery is possible, but this is a constellation of features, and I wouldn't call this a syndrome because of the variety of courses that may be present. But I'm going to give you some examples here, maybe to undermine what I've said so far. I have three cases, just a few features for each. This is a 20-something-year-old whose first recognized seizure occurred when he was 12. But then it was thought that the seizures that first came to attention may have been occurring for a year or two prior to the first recognized seizure. And other seizures followed after. And these seizures are stereotyped with an abdominal sensation that has been described as butterflies or a tingling sensation, so maybe close to an abdominal aura, and then causing deep breathing, which is interesting because it's the opposite of Dr. Wu's comment about apnea as initial feature. And then there's impairment of awareness with motionlessness or oral or manual automatisms for 30 seconds, awakening with fatigue, some confusion, but normal verbal interaction. And so this sounds very classic for a focal seizure of impaired awareness. The aura sounds limbic. The fact normal interaction is intact upon resolution of the seizure suggests maybe it's the language non-dominant hemisphere. And supporting it being limbic is the rare bilateral tonic-clonic seizures. EEG showed bilateral independent temporal epileptiform discharges, and video EEG monitoring showed an onset, but that was, of course, was across the right side the anterior temporal lobe. The fact that the interictal discharges were bilateral independent doesn't indicate necessarily this is bilateral TLE, and the MRI supports it being really right-sided. You can see in the flare in the T2 some hyperintensity in the hippocampus, some blurring of the architecture was clearly evident on the T2 with a normal left hippocampus. And so the MRI here is supporting what we already think is the diagnosis from the history and the EEG. And we get PET scans routinely, and question maybe before, is this really necessary? It's a different topic. But the PET scan showed hypometabolism of the right mesial and inferior temporal lobe, which is consistent with MTLE. We often see hypometabolism beyond the hippocampus if just the hippocampus is abnormal, presumably because of functional connectivity. So for this patient, multiple anti-seizure medications failed. Language fMRI showed left hemispheric dominance, but memory was normal bilaterally. There's no evidence of asymmetry to memory, either verbal or nonverbal. And so because of normal memory function, a WADA test was done, and it was intact bilaterally. So breaking from typical for what is with MTLE, the memory deficit. But the patient had a resection, and hippocampal sclerosis and an FCD was found, type 1, the pole, and the patient's been seizure-free. And so this is maybe a classic MTLE story, except for the memory deficit, which might have to do with the relatively mild findings in the MRI, or maybe a matter of shifting memory to allowing for compensation. So, in contrast, and my point's going to be ultimately one of seeing that TLE is not just MTLE, and MTLE is not just MTLE. There's a patient who's now in her 50s who had her first recognized seizure when she was 47. And this was a bilateral tonic-clonic convulsion, which was brought to medical attention immediately, as such seizures often lead to prompt evaluation. And at that evaluation, it was noted in retrospect that she'd been having memory problems for about 4 months. Her seizures, and she had several other tonic-clonic seizures before anti-seizure medications were initiated, but the seizures never followed an aura. When they didn't progress to tonic-clonic, she had some confusion or greater memory impairment, and these were sometimes subtle. And the question was how many seizures really were occurring was an important consideration in the evaluation. But on evaluation, she had marked memory impairment. She was oriented to her circumstance, being that she was in a medical facility. She knew the day of the week and she knew what city we were in, but she didn't know the name of the facility. She didn't know the month or even the year. Her recall after 5 minutes was for 3 out of 4, but her autobiographical memory was normal and her language was normal. So she had a pronounced episodic memory dysfunction. Her interictal EEG showed bilateral dependence, epileptiform discharges over the temporal lobe, and then a video EEG monitoring showed numerous, maybe more numerous to count, bilateral anterior seizure onsets independently, but with most of them very minimal behavioral change. Sometimes there's a facial expression change, but not much more than that. So here's her MRI, and you see pronounced increased signal in the hippocampi bilaterally, and a contrast scan was performed, and there was no enhancement. The dramatic signal change was interpreted as possible limbic encephalitis. We got a PET scan, and the PET showed marked hypermetabolism in the hippocampi bilaterally. And so I guess you can raise the question of what is status epilepticus and whether her ongoing memory deficit was due to a focal status or not, or was it due to inflammation if this is limbic encephalitis. It's more of an academic question, but she had evidence of ongoing seizures bilaterally. And she did have evidence of an autoimmune process. She had GAD65 autoantibodies with a very high titer. She was started on methylprednisolone. Sorry for the question mark, it was actually intravenous. This helped minimally. She then got immunoglobulins, helped minimally, and started a mycophenolate. The titers came down and seizure control improved. And this was identified through a repeat of the video monitoring. And memory deficits continued. She's had a minimal improvement in her memory. She's now able to recall activities over the preceding few days, but not much more than that. And so she has a tremendous disability because of the memory deficit, which is likely due to the autoimmune process more than the seizures at this point. But is this mesial temporal lobe epilepsy? Well, technically it is, and that this is an epilepsy of the mesial temporal lobes. The etiology differs than the first case. The treatment differs, but it's another version of what can manifest as an adult with temporal lobe epilepsy. So my last case, the third for contrast, is a 40-something-year-old man whose first recognized seizures were at age 5, stereotyped episodes of impaired awareness with right arm stiffening. And so, right here, going back to the idea of limbic versus neocortical raises a question of is this limbic or neocortical? And then it turns out that his seizures really come in 2 manifestations. One is of that right arm stiffening with a mild right facial droop, so 2 motor features, and intact awareness, suggesting maybe this is more neocortical, with durations of less than a minute. The second manifestation, these are distinct seizure manifestations, is of the same right arm stiffening, but in this case, repetitive verbalizations or pharyngeal automatisms, a swallowing type of purposeless behavior. And this is accompanied by impaired awareness, lasting a little bit longer, but then immediate return of mentation. And so, an early motor feature and stiffening, I'm describing tonic stiffening here, not a dystonic stiffening, which can occur with more limbic seizures. But then in the second manifestation, a progression to really much more of a limbic ictal behavior, suggesting more of an MTLE. But turning it around again, the immediate return of normal mentation is much more neocortical. And he's never progressed to a tonic-clonic seizure. And so, I would say that the history here has clear signs of focal onset, but features that support both limbic and neocortical. And the question then is this mesial or lateral temporal lobe epilepsy? Well, the twist here is that the EEG was really bilateral, or someone might even describe generalized. And so this brings us back to Manjari's case of an EEG that is much more generalized or bilateral than the history suggests. And I'm using those 2 terms because the distribution of the abnormality, both interictally and ictally, was across both hemispheres, but asymmetric, consistently asymmetric. And what was found? Well, here's the case for the MRI, the imaging. It becomes the major indicator of diagnosis. Ultimately, it's going to be surgical outcome, which determines, because we end up having a backward approach, and this is, unfortunately. And what one sees is a transmantle sign. One sees a focal cortical dysplasia of the lateral temporal lobe. The sagittal sequence shows that blurring very clearly. And if you can see my cursor, my cursor's not working, across the posterior temporal lobe. And so the 2 manifestations of the seizures may really reflect propagation. And ultimately, we think about any seizure manifestation is due to propagation, and it's the involvement of otherwise normal regions that allow for the manifestation of the seizure. And so the seizures have some limbic features as it propagates into the limbic system, and neocortical features as it propagates otherwise. However, regardless of those manifestations, I would have to call this a temporal lobe epilepsy because of the localization, the focal abnormality that can explain the features. The neocortical presence of this also is consistent with it being a more broad spread EEG finding. The PET is dramatic, that FCD has minimal metabolism. Meaning I don't see metabolism on the PET with really clear boundaries. And for this patient, this gentleman, he also had multiple anti-seizure medications that had failed. Neuropsych testing showed some deficits in attention and perceptual reasoning, so no mesial temporal or limbic deficits. And he had a left posterior temporal resection. It was a type 2B FCD. And seizure freedom has been present for the 6 years since surgery without change to his verbal function. And so a tremendous improvement in his safety and quality of life. So pivoting back to the question at hand, and that's really about pediatric or adult epilepsy, in temporal lobe epilepsy in particular, I want to point out that TLE is an epilepsy type. It's a type of focal epilepsy, and it really is more of a localization. But the localization, even then, is not fully informative because it can be mesial or lateral, which typically equates to both limbic or neocortical. And so the manifestation for TLEs doesn't mean necessarily one thing, even if the localization is consistent. And so it's not a syndrome. We don't have as tight a collection of features as necessary to call something a syndrome. And it's not an etiology either. The pathologies that can cause epilepsy in the temporal lobe are really quite diverse. Ultimately, the manifestation for the individual patient depends upon the localization within the temporal lobe, or maybe more than one localization. And that dual pathology is possible, where a person may have a neocortical abnormality, an FCD, or other pathology, and also a hippocampal abnormality, hippocampal sclerosis. And so each will influence the clinical manifestation. But then the manifestation and etiology are related to age, that certain pathologies are more likely to occur in the child, and certain seizures are more likely to occur in the child compared to the adult. And I would broadly differentiate, and this goes back to what Joyce said a little while ago, that and also Manjari, that with pediatric TLE, the features tend to be more generalized. And by features, I'm including both the manifestation, the frequency, and the EEG, but also the pathology tends to be more diverse in terms of the inclusion of other developmental abnormalities other than FCD, or focal cortical dysplasia. In the adult, the features are more focal, and more often focal including mesial temporal lobe. And that brings us to the first case, the very classic mesial temporal lobe epilepsy. And the EEG also is more focal, indicating more classically anterior temporal lobe. But then the pathology typically is much more confined to the hippocampus, the anterior temporal lobe. But I'm saying more often, I'm not saying always. And so it's a matter of recognizing the spectrum that can occur within this one entity called temporal lobe epilepsy. And recognizing the spectrum, as Sarah pointed out, is of course key in recognizing the possibility of surgical treatment and not missing a patient who might be benefited by more advanced care than medications. So thank you again for this opportunity to be part of this symposium and share my thoughts. And I'm very much enjoying this. Thank you.
Thank you very much, John. Both of you should be congratulated for brilliantly summing it up and providing the entire appropriate knowledge base that was required for this webinar. This is open, so we could have some comments and questions from the panel.
Can I ask one question?
Yes, Professor Ikeda.
Yeah. Thank you very much for the excellent lecture by Joyce and then John. I would like to ask one question to both of you. The presentation with regards to the difference of the semiology between the children and then adults reminds me of that the so-called the faciobrachial dystonic seizure in the autoimmune epilepsy of the LGI1 and limbic encephalitis, which makes that the selective involvement of the mouse and also distal finger, and it is very brief. It is usually the quite rare seen in the major temporal lobe epilepsy, but it's the quite prominent motor manifestation, although it happens in the adults. So it may be the reason why that the autoimmune, autoimmune epilepsy can happen at the middle age without any hippocampal involvement initially, but in subacute way, the hippocampus can be involved in a subacute manner, which can result in that the faciobrachial dystonic seizure, which may share some sort of the similar condition to that the semiology of the temple of epilepsy in the children. This is my questions.
Well, I would, your point about bringing that other condition into the conversation is really quite appropriate, because I think at least it builds upon what I was saying, that it brings the point that TLE is a broad collection of entities. And we end up getting very focused on EEG and behavior because that's historically where epilepsy has been. But I hope that our treatment of epilepsy going forward into the next generation is going to be driven by etiology in increasing ways. And we are doing that in terms of autoimmune and tuberous sclerosis as well. And so trying to take etiology and bring it back to EEG and manifestation behavior is interesting, but maybe a better direction as we think forward is thinking about the use of etiology within classification toward more narrow treatments. In other words, we choose medications based upon their efficacy for a seizure type, focal or generalized or absence. Who does one generalized? And that's downstream from how the seizure develops, what the epilepsy is. And so I'd go that direction.
Yeah, my specific question is that since I'm an adult epileptologist, the faciobrachial dystonic seizure is very rare symptoms in that the adult temple of epilepsy. But my question is that the faciobrachial dystonic seizure, without any, regardless of etiology, the manifestation is more or less common in that the children in the temple of epilepsy. This is my specific questions.
So it was a question about the manifestation of that epilepsy in children, how that differs between adults?
Yeah, this from the viewpoint of the faciobrachial dystonic seizure, that has never been pointed out in the adult temple of epilepsy before that the autoimmune epilepsy has appeared. But I'm just wondering that it is common in the pediatric temple of epilepsy, as opposed to that the adult temple of epilepsy or not, regardless of the etiology.
I think it's a question for you, Joyce.
Yeah, I was just thinking, I'm not quite sure how clearly delineated it is in the pediatric population. And so harder to answer from that perspective. But I do want to add to what John just said as well. Those were the two thoughts in my mind in terms of essentially precision medicine. If we can know the etiology and perhaps the genetic etiologies, kind of like with tuberous sclerosis complex, right? If we can tackle the underlying problem with genetic etiologies, hopefully that's the better way to go in the future versus dividing by brain region or dividing by lobes in terms of, or specifically within the lobe where the seizures may be coming from. I think that that'll be really interesting in the sense that could we tackle it both from the genetic perspective and the surgical perspective? And there are certainly cohorts now being described of both with genetic etiologies and surgical success.
Okay.
Dr. Ikeda, there is some literature which is available. I think it's in epileptic disorders around 2018, where there's a discussion on how the origin of these faciobrachial dystonic events is controversial in that there's a group which believes that they could have a basal ganglionic network or region because the nuclear imaging of the PET shows hypermetabolism in the basal ganglia and there's dystonia in the events. The ictal EEGs in that particular article were not always abnormal. 30% of them had no ictal correlates during the event, and the rest did have brief discharges, which were rather frontal central. So I don't know if we could equate the temporal or FBD events in children and in adults, but there seems to be some kind of basal ganglionic involvement, which of course we do see in temporal lobe events also later. So I'm not sure if I would like to think about them from that perspective.
Yeah, thank you very much. That's a very important point. That the reason why I bring this facile brachiodystonic seizure is that we quite often encounter that the myoclonic components of the facile brachiodystonic seizure. So the facile brachiodystonic seizure is some sort of a composite semiology, including myoclonus, and then the twitching of the mouth, and then dystonia. So it may mimic to some extent to that the periorthandic manifestation of the pediatric TLE. Thank you very much for your comments.
Just another element to this, which Akio, Joyce, and John have already highlighted, is we all know that seizures are just a symptom. And if we don't understand the etiology, we aren't doing well enough very often. And the autoimmune anti-GAD patient of John's is a great illustration of that. Whether in status or not, the seizures are a symptom of a process that needs treatment of itself rather than just focusing on seizures. And that, a bit like Joyce was mentioning with respect to trying to drill down on etiology and in a parallel way treating seizures and etiology, hopefully better, will do better for our patients.
So, any other comments? So I think we have come to an brilliant ending to a series of 7 episodes dealing with temporal lobe epilepsy, and all of them will be put up on the ILE website, and definitely they will provide a powerhouse of information for practical algorithms for anybody who wants to have a complete overall idea. And Professor Kawai, would you like to give the closure?
Okay, so first we started with right temporal lobe epilepsy as a kind of basic of temporal lobe epilepsy surgery, and we move on to the left dominant side temporal lobe epilepsy, and the case presentation by the Australian group, and then we discussed about tumor and tumor-like conditions in MRI negative temporal lobe epilepsy surgery. And the last time we discussed about red flags for major temporal lobe epilepsy and temporal plus epilepsy. And this time we discussed about the semiology, the difference in pediatric and adult temporal lobe epilepsy. And so that is a kind of, comprehensive didactic and a case-based webinar series of temporal lobe epilepsy. And we hope that this series will really help you, particularly in our colleagues in developing the source limited and developing countries who kind of try to found the epilepsy program, epilepsy surgery program. And from next time, we'll move on to the frontal lobe epilepsy. The next webinar will be held on March 25th. This time, it will be Friday night. And the time is go back to normal. The start the 5 o'clock in India and 8:30 in Japan. And we want to see you all the next month. And for today, we really are grateful we could have the two distinguished lecturers, the Professor John Stern and the Joyce Wu. And I think we had a very deep discussion and nice didactic lectures. So this is now we close this the syllabus, the webinar series.
We can have a final word by Professor John Dunn and Professor.
Oh yeah, sure. Please, Professor John Dunn.
Oh well, hey, here I am in Western Australia, and here we are talking around the world together. And this illustrates that despite this crazy world and the many challenges that we face, together we can make a difference. And I'm a complete believer in this positive force that we're a part of. And that includes supporting and caring with our patients with epilepsy. And for many, where epilepsy surgery can rescue them from a life of misery, them and their families. And this is the reason we're doing this stuff. And I'm very grateful to Sarat and Kenzuki for heading this task force in our region with Manjari's capable and wonderful support and the support of great people that we have today, Joyce and John. And it really makes my heart beat stronger that we can make a difference, and we have to keep positive. Thank you.
Professor Ikeda?
Yes, thank you very much for all of the effort, especially that the Joyce and then the John for the excellent lecture in spite of the unusual time for both of you. So this web conference in the global fashion would promote the interactive discussion, and then they promotes that the benefit for the patient with epilepsy. So although the corona's pandemic will disappear, we could continue discussing with face-to-face as well as that the web conference style, which makes our activity more devoted to the patient with epilepsy. Thank you very much for all the great endeavors. Thank you very much.
So thank you very much. I think we have come to the end of this webinar. So we close now.
Thank you all. Bye-bye. Have a great day.
Bye.
See you.
Thank you, everyone.